Hello and welcome to the channel. Well, this video is mainly intended for eye surgeons for training purposes, and I would advise via discretion for all the surgical videos shown on this channel. Hi, this is Dr. Prashant Shukla, and if you like the video, do like, share and subscribe the channel, help the channel to grow. Today I have come up with an interesting case of a white cataract in which I am going to perform manual small incision cataract surgery. She is a 65-year-old female patient, and the eye is very deep seated and she has got a very high nasal bridge. This is the left eye of the patient, and we have planned to do a MSICS. Let's start the surgery now. By this time the superrectus suture has been already given. Here I have taken an angled MVR blade to make a side port on the right side and one side port on the left side, because I intend to use a bimanual irrigation aspiration for cortical removal. Time to stain the entry capsule using trypan blue dye. After a few seconds the dye is being washed out using BSS. There is a lot of pooling of the fluid in the sac because of the deep seated nature of the eye. In a moment it will be removed by my assistant. Entry chamber is now being filled up using Visco Elastic. Here initially my plan, I thought it would be an intumescent cataract, and my plan was to do a two-stage rhexis. But after puncturing the entry capsule, I could see that there is no fluid egression from the lens. So here I am going to do a Whoorling type of Capsulorhexis. This technique of doing Capsulorhexis is very good because the flap is long and thin and it's got an excellent control. The moment the rhexis, if all tries to go to the periphery, can be just retrieved back very easily. So in this case, when we are towards the end of the circle, we just slightly move the rhexis away and take then make a small long flap, just like a snail track. Because in these cases sometimes there can be fluid pockets in the periphery also. So if we have this kind of a flap, then things become very easy to control and to avoid the Argentinian flag sign. So now we are towards the end of the rhexis. Problem here I am facing is that because of the high nasal bridge, there is not much of space to move the forceps, and eye constantly goes out of focus. Rhexis has been done, and this is the entrocapsular flap, long thin flap, which comes out after doing this kind of a rhexis. Here I have got a decent sized rhexis, about 5.5 to 6 millimeters, and now I am going to make the conjunctival opening. This surgery is minimally edited. A limbal base conjunctival flap is done. Some mild bipolar wet field cautery is done to take care of the bleeding blood vessels. A lens tip blade is then used to make a frown incision of about half scleral depth, and then a crescent blade is then taken to make the sclerocorneal tunnel. Here the incision is about 1 to 1.5 millimeters from the limbus, and another 1.5 millimeters we are going to enter the cornea, so that we have a very good self-sealing incision. The incision is made on the left side. Here I am holding the eye at a very unusual place, because on the left side the hold was not very proper. So the tunneling is already done, and now I'm going to take a 2.8 keratome blade to open the anterior chamber. The opening is done only while moving forwards, and by doing this we have got a very smooth and almost parallel to the limbus like opening. Some hydrodissection is done. This is then tabbed, although not much hydrodissection is needed in these kind of cases, because we have a very milky and soft cortex also. Now there is the time to remove the cataract, and here I will be using a bimanual way to prolapse and using 2 Sinskey hooks. I will be just wheeling out the nucleus from the capsular bag. The equator is hooked, and both the Sinskey are then used to just wheel out. The size of the nucleus is not very big. Well, these kind of cases with white cataracts, it's not very important, or it's not always like we have a very big nucleus or a hard nucleus. There are multiple variations of these cataracts. So putting some Visco Elastic both in front and behind the nucleus. Be doing a phaco sandwich technique. The Sinskey just goes above the nucleus and the vect is behind, and the nucleus is removed. Here we have got loose white cortex, and which will be removed maximally by just the irrigating jet of the bimanual. Majority of the cortical matter loose is just irrigated out, and now I'm going to take both irrigation as well as the aspiration handpieces to just remove whatever cortical matter is left into the capsular bag. The vacuum being used is about 350 and bottle height is about 110. Aspiration flow rate is basically managed by the machine, because this is a Venturi system, and the cortex is held from the equator and then brought in the center and then aspirated. We should always try and aspirate the cortex in the center, not in the periphery, because many a times inadvertently we can catch hold of the anterocapsular margin sometimes, and then we can have a zonular dialysis. So it's always a good idea to just bring the cortex in the center. Hands are switched, the cortex from the other side is removed, almost all the cortex is removed and the bag is very clean. Time to implant the intraocular lens. Here I am going to put a single piece PMMA non-foldable intraocular lens. One haptic goes straight into the capsular bag below the intracapsular opening, and using a Sinski hook now, the other haptic will also be dialed. First the optic haptic junction is held to get the lens inside, and then through the dialing hole the other haptic is also dialed into the capsular bag, and the lens is oriented properly into the correct orientation. Now the lens is well centered, and time to remove the Visco Elastic, which is both in front and behind the intraocular lens. Just make sure to remove almost all the Visco Elastic. Well, I try to get more and more videos on small incision as well as phacoemulsification. So if you do like the video, just subscribe to my channel and hit that bell icon for more updated videos and notifications. That's it. Case is done, and time to close now. The irrigating jet is also used behind the intraocular lens to just irrigate out if all any viscoelastic is there. Side ports are hydrated on both sides. We have got a very nice chamber. There is no leakage, chamber is well formed. Still I am going to put a suture in this case, just one 10-0 nylon suture to counteract the against zero astigmatism which would have been caused by this incision. By putting one suture, one can reduce the post-operative astigmatism to a greater extent, because here I am operating at 12 o'clock. Had I been operating temporally, then you need not put a suture, but in this case, because the patient has a significant against the rule astigmatism also, so and this incision can increase that astigmatism, so this one suture can help reduce the astigmatism to a greater extent. One can always put, and the knot would be just rotated and buried inside the sclera. Knots are cut. Some moxifloxacin is instilled into the antechamber for prophylaxis. That's it. The case is done. The conjunctiva will be closed using cautery. The patient did well. Thank you so much. Hope you like the video and hope it's going to help you in your learning curve, and keep following for more such updated videos. Have a nice day.